Hi, thank you for allowing us to present the continuation of our work previously presented last year on the effects of socioeconomic status on bariatric surgery outcomes. These are our disclosures and they are not pertinent to this study. Socioeconomic status has been studied with bariatric surgery outcomes, and many studies have shown it affects access and outcomes postoperatively. SES is difficult to measure as it includes multiple demographic factors that are not readily identifiable in the chart. The Distressed Communities Index is a socioeconomic status geocode that measures community economic well-being. It has been used in surgical literature, including in improving surgical risk adjustment models. There were 2 previous studies done at our institution using our patients who underwent primary Roux-en-Y gastric bypass and sleeve gastrectomy and stratified patients based on socioeconomic status and Distressed Communities Index. Our study showed that patients from lower affluent areas had longer time to discharge, had more readmissions, more 30-day complications, and although they had similar initial weight loss, had more weight recurrence and long-term follow-up. Both studies showed that our patients in our lower resource communities were more vulnerable. However, since those 2 studies were conducted, there were significant changes to our healthcare delivery system due to the COVID-19 pandemic. There has been a lot of research looking at the effects of COVID-19 on surgical delivery, including reduced access to bariatric surgery, a change in who was receiving bariatric surgery during this time, and changes in postoperative outcomes for elective surgeries, although post-op outcomes in bariatric surgery during the COVID-19 pandemic is limited in the United States. So the aim of this study was to evaluate our outcomes after the COVID-19 pandemic and to see if our previously shown socioeconomic disparities existed. Patients were stratified into 2 groups. The high-tier DCI group included prosperous, comfortable, and mid-tier communities, and the low-tier group included at-risk and distressed communities. Patients were also stratified into pre- and post-COVID based on surgery date with March 1st, 2020 as our cutoff. This was a retrospective chart review using patients who underwent primary Roux-en-Y gastric bypass or sleeve gastrectomy between 2015 and 2022. We used weights calculated at their post-op visits. Data was done to compare pre- and post-COVID groups and high-tier and low-tier groups. There were 709 patients included, 588 were pre-COVID and 121 were post-COVID. These groups did not differ in age, race, sex, or ethnicity. These groups also did not differ in their DCI category or in their stratification into high tier or low tier. Post-COVID patients were more likely to have public insurance with an increase from 37 to 46%. We saw our VA and Medicaid insurance rates increase with similar Medicare rates. Post-COVID patients were also more likely to undergo Roux-en-Y gastric bypass, 56 compared to 69%. Pre- and post-COVID patients had similar ASA statuses. Post-COVID patients waited on average 3 months longer for their bariatric surgery, and at the time of surgery, post-COVID patients had a lower BMI, which was statistically significant, but likely not clinically significant as it's 43 compared to 44. Between initial consultation and the date of surgery, pre- and post-COVID patients lost similar % of excess weight loss. Pre- and post-COVID patients had similar length of stay and similar % discharged on post-op day 1. Post-COVID patients were much more likely to follow up at 6 and 12 months. The 30-day postoperative outcomes and complications between the 2 groups were similar, with similar readmission, dehydration, and death rates between the 2 groups. There was less wound complications in the post-COVID cohort, although this was quite rare with only 1 wound complication in our post-COVID group. A multivariate analysis controlling for age, sex, type of surgery, among other things, did show a lower rate of any complication in our post-COVID group, and our wound complication rate was no longer statistically significant. Post-COVID patients lost more weight at 6 months, which was 54 compared to 48% excess weight loss, and also lost more weight at 12 months, which was 67 compared to 58% excess weight loss. When controlling for type of surgery, among other things, the 6-month weight loss was no longer statistically significant, but the differences persisted at 12 months. When analyzing our post-COVID group, we divided them into the high-tier and low-tier groups, and these groups had similar length of stay and percent discharged on post-op day 1. These groups also had similar rates of complications despite the previously seen differences in our pre-COVID cohort. These groups also followed up at similar rates. And these groups lost similar percent excess weight loss at 6 and 12 months. So in conclusion, pre- and post-COVID patients were similar, except post-COVID patients underwent Roux-en-Y gastric bypass more often and waited longer for their surgery. The longer wait time likely reflects the transition in our hospital system with prioritization of urgent procedures. The length of stay and percent discharged on post-op day 1 were similar, but our follow-up rate was much higher in our post-COVID cohort, which likely reflects the increased utilization and standardization of telehealth visits. We also saw lower complication rates with our post-COVID group, which may be reflected or may be due to an increased follow-up rate. Our post-COVID patients lost more weight at 6 and 12 months, and the 12-month difference was significant even when controlling for that. They underwent Roux-en-Y gastric bypass more often. This is not entirely clear why. The data on follow-up rates and weight loss is mixed, but our increased follow-up may be contributing. And most notably, the differences that we saw based on socioeconomic status before COVID were no longer present post-COVID. We do need further studies to determine which specific changes to our healthcare delivery resulted in these increased weight loss, better outcomes, and reduction in disparities. And this is very important to make sure that we're delivering equitable care and improved outcomes for all patients regardless of socioeconomic status. And with that, I'll take any questions.